We'll just wait for Dr. Gurmeet to switch on the video, then we'll start. Yeah, we have it now. So good afternoon, everyone, and thank you for logging for today's session. It's a very important session today. Everyday problem I think we face day in and day out, and the diagnosis of hemoglobinopathies is something which is very important for us in our day-to-day practice, and we will hear from one of the very esteemed faculty today via different case scenarios how it can be sometimes challenging to diagnose some of these rarer variants of hemoglobinopathy. So we are very privileged and honored to have Dr. Gurmeet Singh today speaking to us on the lab diagnosis of hemoglobinopathy. Dr. Gurmeet Singh is DM in lab hematology and heme pathology from All Institute of Medical Sciences. Presently, Dr. Gurmeet Singh is the senior consultant and the head of the heme pathology at Jawaharlal Nehru Hospital Research Center, Bhilai, which is the Steel Authority of India hospital. So thank you very much, Dr. Gurmeet, for getting time out and sharing your experiences with us today. This is basically a weekly webinar online teaching session kind of a thing which we have been doing for the last few months. We have got colleagues in pediatric hematology oncology who are practicing. Some are fellows in training who have logged in. And I think your session is going to be very, very, very important, and I think clear a lot of our doubts which we have with regards to the lab diagnosis. Dr. Gurmeet is a very accomplished teacher and has guided a lot of students in their theses, and he's well published. So we'll be hearing from him how to diagnose hemoglobinopathies and some of the rarer cases he's going to share with us today. Now, I would request everyone, I think this is a request from ECHO team who have been kindly giving us this platform for the last so many months. And I'm requesting also every week that we need to keep our videos on, please. Because then only is going to be interactive, and it's also nice for the speaker to see faces and at least interact with people, not with a blank screen. So please keep your videos on, and as usual, you can put your question in the chat box or raise your hand at the end of the session, and then we can discuss once the presentation is over. Over to you, Dr. Gurmeet.
Thank you, Sunil, for those kind words. You have made my job a bit difficult because you have beforehand said that he is a good teacher. So I hope I'll be able to meet up to your expectations and the bar that you have raised for me. So when I was told to discuss with you how to diagnose the hemoglobinopathies, and it had to be a case-based discussion, as was discussed between us. Why case-based discussion? Because that is what we are facing in day-to-day problems. The problem is, it is that there are a number of guidelines. There are a number of guidelines. We are all reading it. Those guidelines are something that we can go through. But once the time comes to implement those guidelines on your day-to-day practice, sometimes it becomes a bit difficult, and we don't always have all the resources. So what I'll be discussing today is how we can diagnose the various hemoglobinopathies and with the available resources that we have.
Are you not able to move the slides, Dr. Gurmeet?
No, it's okay. No.
Okay.
So I'll start with just a brief introduction from where I am. It's Bhilai, Chhattisgarh, as Sunil said. It's a hospital that I work is in from Steel Authority of India Limited of Bhilai Steel Plant. This is how our plant looks. It's a very picturesque thing. What we are known for is making of rails. And in fact, the amount of rails that we have made can circumvent the globe many times. This is our hospital that I work. But unfortunately, we also fall in a bang in the middle of a belt for sickle cell in India. So why I was telling you about my place and what we have here, that is a village steel plant, is because we have a cosmopolitan population. being a steel plant, people from all over the country have come and joined the steel plant. So we have intermingling of various people from various origins. Say someone from Punjab marrying someone from down south Tamil Nadu, someone from Odisha marrying someone from Assam. So we get a lot of mixtures of hemoglobinopathies, the combinations that I'm very fortunate to see. So just a brief recapitulation of what our hemoglobin is. It is made up of two alpha and beta chains. So it's not exactly alpha and beta. We can say that it's a alpha is a group of alpha gene and beta is also a group of alpha gene which are expressed at various times during the development. So during the embryonal period, we have an embryonal hemoglobin which persists till about 6 to 8 weeks, after which hemoglobin F starts taking over. And this fetal hemoglobin peaks at around 24 weeks. And at birth, the level is approximately 70%. Why it is important to know these percentages is because when we get a tracing of an HPLC, we should correlate it with the age, whether the hemoglobin F is appropriate for that age or not. Otherwise, we'll be misled. It will be misleading. Again, the adult hemoglobin, it takes over by after the birth slowly, and by the age of 1 year, the main hemoglobin is the adult hemoglobin, with HbF being less than 1 to 2%. Occasionally in pregnant females, we can have an HbF which is up to 5%, but beyond that, we should think of something else. So what are these hemoglobin abnormalities that we are going to look for when we look at the HPLC tracings? So this could be the structural or qualitative abnormalities like the sickle cell disease, the HBE, the HBC, HBD, etc. Or it could be the quantitative, that is the production of one or more of the globin chain is reduced, or rather it is absent in some cases. Now the third variety which is important to remember is that there may be a case in which the switching from a fetal to the adult hemoglobin does not occur. And such a condition is known as hereditary persistence of fetal hemoglobin, and it sometimes causes some problems in diagnosis of certain conditions. Most important thing while diagnosis of hemoglobinopathy is the clinical information, because that is something we are looking forward from you all to send to the lab. What is the degree of anemia, whether the patient has required any transfusion or not, whether there is any organomegaly, what about the family history, is there any pain crisis, what was the onset of jaundice. In view of these findings, we look at the hemogram. We don't not only look at the hemoglobin levels, we also look at the RBC count, the indices, and the RDW is very important because this is something that helps us differentiating between iron deficiency anemia, which is very common in the growing age, from a beta thalassemia trait. And of course, the peripheral smell examination, which will give us a very good clue what we are dealing with. Once we are sure that we are dealing with some form of hemoglobinopathy, there are two ways to diagnose it. Earlier, we used to do the simple hemoglobin electrophoresis, which was either alkaline or acid electrophoresis. And now, most of the time, HPLC is done. And it is fairly common. Almost every place has it. Every hospital will have it. Those who don't have it, outsource this. And we get the tracings and the results. Now, why I emphasized on the outsourcing point is because once we when we are sending the sample, we should be sure that the patient has not received transfusion in last few days, and that last few weeks, in fact, and proper history should be given so that the person who is interpreting these chromatograms can do it in a correct manner. Otherwise, the clinician who is sending, it may get an incomplete information, and that could lead to difficulty in diagnosis and further treatment of the patient. Just to show you how the electrophoresis look like, because nowadays you won't see this. There was a positive anode and a negative charged electrical field, and from the origin, the hemoglobin based on its charge move towards from one end to the other end, and based on their separation, they were grouped together in various groups like hemoglobin E, C, A2, then hemoglobin S, D Punjab, D Iran, Q India, and so on. Now, the main difficulty with this was the standardization of the technique, which later became easier because of automation of the instruments. And second was that we were not able to differentiate between the groups of hemoglobins which were together. So a second method, hemoglobin electrophoresis at a different pH was tried. This again led to a separation based on the electrical charge. And yes, we could separate some of the groups, but again, they found some new groups. And so the next step, that is the hemoglobin, the HPLC, or the high performance liquid chromatography, was came into vogue. And number of instruments are there, number of companies make it, they all make different instruments, but the most common used is the variant and the variant 2 of the Biorad. And all the graphs that we get on the textbooks are generally from the variant or the variant 2 machine. It is an automated machine. Runtime of the program that is used is approximately 6.5 minutes, and sample required is very less. This is what is a heart inside the machine that makes it work. There are two different pumps. There are two different buffers. These two pumps mix the buffer at different dilutions and pass it through the chamber. Herein lies the cartridge through which sample is passed. The sample, this is the cartridge. The sample goes from this end to this end, and it goes and attaches to the carboxyl group of the silica. Now, once the buffer is passed, the hemoglobin, which has less affinity to the carboxyl group, comes out first and is detected by the photo detector, which is somewhere here. And this detection is then shown in the form of a graph. We'll see how that graph looks like and what are the points that we have to see when we are reading a graph. Now, this beta-thal, the variant system of Biorad, has a number of programs. The beta-thal short program is the most commonly used one because it is a good mixture between the separation and the time taken. It takes 6.5 minutes, as I said. Alpha-thal short is used for neonatal screening for HPH. Sickle cell short program is used for neonatal screening for sickle cell disease. And hemoglobinopathy program, it takes 20 minutes to run a sample, but the separation is very good. And as a byproduct, we can get HbA1c by the program that is a beta-thal short program. We can know the HbA1c. That is not very important in young in kids, but it may be important in adults. So what are the chromatogram that you get, and what are the part that we have to look for? This is how a chromatogram looks. Now, what is it? The x-axis is the time, and the y-axis is the absorbance. So there are peaks. Now, from the time from which a peak starts to the time at which this peak ends, this is known as a window. So suppose this is some, say, HBS or sickle. So time at which this peak starts and time at which it ends is known as a sickle cell window. Now, this sickle cell window does not necessarily have only sickle hemoglobin. It may have other hemoglobins also. So how do we differentiate it? That we'll see along the course of our talk. So this is the peak. This tells us about the percentage. The peak where it for the perpendicular to the timeline tells us about the retention time. The retention time is important because within the window, there are different hemoglobins which will have subtle differences in retention time. And these retention times are very important while we diagnose the disease. Now, the area under the curve will tell us about the percentage of hemoglobin that we are looking for. Now, this is a typical chromatogram from a normal HPLC. See, we have most of the hemoglobin is hemoglobin A. Hemoglobin A2 is around 6% and rest P2 and P3. So what are these P2, P3? We'll see. And hemoglobin F, as I said, it is less than 2% in a normal person. So these are the windows that I was talking about. So every hemoglobin has a name and a window associated to it. That is the F window. It does not necessarily contains only fetal hemoglobin, but some other hemoglobins also. This is a chart from the Barbara Wayne's book of hemoglobinopathy, and this is something which I suggest all of you to go through and keep going through it, because it tells us by this way it comes to our tips that what we can expect, what other variants we can expect there. So what was that P2 that we were talking about? P2 is nothing but a glycosylated form of HVA. P3 is another window in which we get some variants like the J Merit, the J Baltimore. J Merit is important because we get it in India, and a number of others. And in P2, the glycosylated A is the one that tells us about hemoglobin A1C. That is the level of hemoglobin A1C. Then hemoglobin A, that is the normal hemoglobin. It is not alone in this group. There are certain other hemoglobins also. Similarly, A2, which is very important. There are a number of hemoglobins, especially E, which is very common in India. Then hemoglobin D, that is D Punjab in our country, and some other variants of G. Sickle is not alone again. It has some other hemoglobins, the most important of which is A2 prime. That is A2 dash. Why it is important is when the percentage is 1 or 2 in a sickle cell window, we should always think of A2 prime. This is a variant of A2, and while diagnosing a case of beta thalassemia trait with a patient who has an indices which is very suggestive of it, we should add this A2 prime with the original A2 and then look at the final A2 value, which should be more than 3.5 to have a suspicion of beta thalassemia trait. And hemoglobin C, which is not very common in India. So these are the various windows. So what are the main hemoglobins for each window? So A2, HBE, Lepore, and D Iran is something that we should be very careful of diagnosis. How will we do it? We'll see further. HBD window, based on the percentage, we can say whether the patient is heterozygous or homozygous. Similarly with HBC. So let's start with some of the cases. We'll start with something which is very familiar to all the pediatricians. That is I hope everyone of you will be able to say what it is. This is a 1-year-old child who presented with anemia. So we can see HbF is very high, HbA is very low, HbA2 is normal. So this is a typical find of a beta thalassemia homozygous. Why I have showed this is how to interpret the HbF values. So fetal hemoglobin up to 5% may be seen in certain cases of in some pregnant females, sometimes in MDS and aplastic anemia and beta thalassemia trait also. And of course, it is normal. So up to 5%, we are not very much worried if we know that she's a pregnant female or she's a known case of aplastic anemia. But if we have a chromatogram tracing in which HbF was say 2% earlier and it has gone up to 5 now, so we should suspect something. Maybe it is MDS, or we should have a serious look at that patient if the other clinical findings are favoring it. Now hemoglobin F of the percentage 5 to 15, there are certain beta thal trait variants which will have this hemoglobin F of say 7 to 8 to 9% sometimes, and this is very important to keep in mind. Something which is between 15 to 45, we should think of HPFH, heterozygous state, that is hereditary persistence of female hemoglobin heterozygous state, or beta thalassemia homozygous state who has received transfusion and has come to you. So herein lies the importance of transfusion history. Suppose kid has received a transfusion, and immediately a week after that we send a HPLC, we may get a HbF percentage of somewhere around 45 to 50%, and then it will be a bit of a question mark what really it is. And of course, if it is more than 90%, we should think of homozygous thalassemia if the patient is symptomatic, and if the patient is totally asymptomatic, then it is hemoglobin hereditary persistence of female hemoglobin. So here is the importance of taking the history, because if the patient is symptomatic, then a diagnosis is beta thal. If the patient is asymptomatic, then the diagnosis is hereditary persistence of fetal hemoglobin. Coming to the next graph, it is a classical case graph of beta thalassemia trait, that is heterozygous beta thalassemia. We see the HbA2 is 5.1, that is it is raised. Normally it should be less than 3.5, and in this F was 0, but F can be raised, as I said, up to sometimes even up to 5 or 7%, but generally it is less than 2%. A2 is very important because there are a number of other hemoglobins which elute in this window. So what are those? If A2 value is very low, if it is less than 2, we should think of alpha thalassemia in a patient who is anemic. If it is between 2 to 3.5, it is normal. And it could be delta beta if the A2 is very, very low. So we should keep that in mind. A2 very, very low, delta beta, A2 low less than 1.8, alpha thal trait, and up to 3.5, between 2 to 3.5, it is not. So what about a value of 3.5 to 3.9? There is a controversy. Some say more than 3.5 is beta thalassemia trait, but in our country, IDA is very common. So we should think of beta thalassemia trait with IDA and should confirm it after correction of iron deficiency. And A2 of less than 9%, but more than 4 or more than 4 is beta thalassemia trait. And with more than 9, it could be HbE syndrome, it could be HB Lefort, or it could be HBD era. This is a classical graph of chromatograph of sickle cell trait. Here we see HbS, a level of around 35 to 40%. Here it is 38%. So in a HbS, that trait, that is sickle cell trait, the hemoglobin S is generally up to the level of 40% or 42%. If hemoglobin S is more than 50%, and we should look at the indices. If the indices are microcytic hypochromic, then we are dealing with some compound heterozygous state, that is HbS with beta thalassemia. And we should always do a family study in such cases. And if HbS is very high, then it is homozygous sickle cell trait. That is HbS of more than 80 to 85%, or sometimes even above 70%. Because in India, we have seen that HbF is high compared to the population in the Africa, and that is probably one of the reasons that it is said that the Indian sickle cell variety is a bit benign variety. But being in a sickle cell belt, I can tell you there is nothing benign about sickle cell disease. It has a very debilitating effect, and it becomes very difficult sometimes to handle these patients. This is a classical graph of HBD trait. Here I want you to look at this retention time. See, it is 4.06 here for HBD, and it is 4.3 here for HbS. So these two are very close to each other, and we should pay particular attention. So now we'll see the difficulties that we have faced in some of our cases, and how we went about resolving it with minimum of resources. You can say that with a limited resource setting, how can we go about it? So this is a classical chromatogram. See, here we can see a S window. It is 85% of sickle window. So this looks like a classical case of homozygous HbS. 85% of S, hemoglobin 10.9, okay, it could be there. But what about this MCV 60? Why it is 60 here? So what we can do about such cases? These two things don't match. Sickle cell disease will always have generally won't have an MCV of 60 unless it is associated with alpha thalassemia. Could it be associated with alpha thalassemia? But again, with a S of 85, we are seeing that HbF is very low. It is only 1.4%. So are we really dealing with sickle cell disease, or is it something else? To confirm it, the British Society of Hematology says that you should always do two types of tests to confirm a diagnosis. So we did three types of testing. The first one was HPLC, second one was electrophoresis. But before doing an electrophoresis, we did a sickling test because that is easier to do. We can do a sickle solubility, we can do a sickling test with 2% sodium metabisulfite put on a slide, look after say 2 hours, because in sickle cell homozygous cases, you can see sickled RBC instantly. So sickling was negative. We did an electrophoresis, but the electrophoresis is showing a band which is in the region of HbS. Now the important, as I showed you earlier, is that this band is something which has other hemoglobins also with it. So what are the other hemoglobins? So it is sickle cell, along with sickle cell, that is S, D, G, and Lepo. That is how I remember it. So sickle cell S, HBD, then HB Lepo, and G, HBG. Then we went back because we didn't have the history. The patient used to live in one of our mines. The husband worked in a mine. So the patient, when we contacted the patient, she said she never had any sickling episodes. She never had any problem related to her hemoglobin. Her only problem was that she was a known diabetic, and every time they used to send a sample for HbA1c, the report came back as HbA1c not quantified because they were using a method of HPLC. So as she was totally asymptomatic, her sickle cell test was negative, but she was having a HPLC, she was having a band in the sickle cell region. In electrophoresis, she was having a band in the sickle cell region. So what we did was, we again recalibrated our instrument and we rerun this sample. Now we got the same patient sample has come in the D window. So what is important here is calibration using HbA2. See, HbA2 has a retention time of somewhere around 3.65 to 3.7. So when the calibration, when the retention time goes haywire, we can adjust the temperature and bring it back to the normal. So that is what we did, and we got the real picture, that is HbD window and a HbD of 85.2%. So now we can explain all the things that the patient had. She had HbD, the acetylated, the glycated forms of HbD won't go till the region of P2. They will be somewhere around this A0 or somewhere around some unknown peaks. So her HbA1c was not being quantified, and the first HPLC gave us a wrong impression that she was a case of sickle cell disease. These are the two side by sides. You can look at how the subtle difference in the S window and the retention time of the two hemoglobins. The retention time of sickle is generally 3.9, and D, it starts from 4.10. So the subtle differences will make us have a wrong diagnosis. So the lesson to be learned from this case is clinical history is very, very important for the interpretation of HPLC. So my request to all my clinical colleagues, please send the clinical history along with the form that you are sending. So now coming to case number 2. Since I have talked about the history being very important, so I'll start with the history. So my clinical colleagues have listened to me and they have sent this history. It's a 7-year-old female, symptomatic anemia since long, recurrent episodes of jaundice, transfusion of fluid, last was 1 month back, She had a pallor, icterus, and hepatosplenomegaly. So CBC showed an HB of 8.8 with a microcytic hypochromic picture. So what we did was, we told her to follow up after a few days since she had a recent transfusion, and then we repeated her this we did an HPLC. Now HPLC shows an HbA which was very normal and HbA2 was 1.6. Is it normal? As I said, HbA2 of anything less than 1.8, we should always be suspicious for alpha thalassemia. But what is more important is these two peaks that we get here. So these peaks have a retention time which are well below the detectable limit of the machine. So in variant 1 that we had at that time, the detection limit was 0.6 minutes. So anything less than 0.6 minute, it would not quantify. So this M peak pattern is very important and we should look for it. This is a very common in cases of neonates, this M peak pattern. Why? Because they have a HbF which is very high, and the glycated forms of HbF go and elute in this region. So in a neonate, we should interpret it with caution, but in an elder child or someone who is an adult, we should definitely have a look at this. So confirming it by some other method, we did an electrophoresis at pH 8.6 and we got a fast moving band. This fast moving band is nothing but HbH. But so we wanted to confirm what this HbH was. We did a brilliant crescent blue stain and we got a typical golf ball inclusions. So to summarize this case, a 27-year-old female, microcytic hypochromic anemia, HPLC peak less than 1 minute with low H2, a fast moving band on across gel electrophoresis, and gold wall inclusions of brilliant glycine blue staining. So it is HBH or BARTS, since BARTS is not compatible with the age 23, so more likely to be an HBH disease. As I said, the caution is acetylated form of HbF can be seen in this region along with this M as an M band peak, and in cases of hyperbilirubinemia, there is a peak which is less than 0.6, and we should interpret the results very cautiously in such cases. So the message for this case was reading your HPLC tracing, if you get it, is very important, as different HB has different percentages and different retention times, and you should look at all the peaks in the chromatogram and not only what the percentages are being given. And any abnormal peak, you should suspect a hemolytic anemia if it is compatible with the clinical picture. And of course, the ancillary investigations will help you in reaching a diagnosis. So coming to our next case, she's a 30-year-old primary gravida, attended the antenatal clinic, had anemia, was referred for further evaluation. So microcytic hypochromic picture, HB of 9.5, MCV low. Most common thing that comes in mind is iron deficiency anemia, but an HPLC is done as a part of a routine. So we did an HPLC and we got an unknown peak. This is an unknown peak and the retention time is 4.7. Now, unknown peak is something which you can get at any point of time in the chromatogram, and any unknown peak which has a percentage of less than 7 is generally ignored. Less than 7 to 10, between 7 to 10 is something which we look at with caution. But if it is more than 10, then it is significant and we should search why it is there. So we got an unknown peak shown here as unknown 2 with a retention time of 4.7 and a percentage of 18.2. So what could be the diagnosis? This is a very characteristic peak. It is the church spiral pattern, as they say, tall dented peak. In India, whenever it comes, we should think of Q India. So HBQ India is something that we should think of whenever we get such a peak. it can again be confirmed by HB electrophoresis, and this abnormal HB will co-elute with the region of in the region of HPS. But HBQ India is asymptomatic. Still, that does not explain the anemia that this patient is having. So what should we do? As I said, iron deficiency anemia is very, very common in our country. So iron studies should always be done. This patient has a transferrin saturation which was very low, and a diagnosis of iron deficiency anemia in case of Q India was made. There is a beautiful paper from AIMS. They had looked at the cases of Q India along with IDA, and they found out that this along with beta thalassemia trait or iron deficiency anemia, and they have proven that yes, this iron deficiency anemia can cause low HB, and we should correct it and then look at the tracing, look at the patient's profile. So the message here is that there are few hemoglobins which should all be which are asymptomatic in individuals. If we diagnose that and the patient is symptomatic, then we should look at other causes of anemia in such cases, not rest on that we have an abnormal hemoglobin. Coming to case 4, a 25-year-old female detected with heterozygous beta thalassemia on routine checkup during her pregnancy. As a rule, whenever a patient is heterozygous for any of the hemoglobinopathies, husband is also tested. So her husband underwent a routine checkup to rule out the hemoglobinopathy. Husband was asymptomatic. There was no organomegaly. Hemoglobin was 14, normal indices. But the HPLC tracing shows an A2 value which was around 40%. So what is this A2 of 40%? Could it be something which we should be worried about? But first we should know what it is. So A2 of more than 10% or 9%, we should think of certain things. One is HB Lapore, one is HBE, one is HBD Iran. Now HBE has generally in heterozygous state, the hemoglobin percent, the HBE percentage is approximately 25%. So anywhere around 20 to 30%, it could be HBE. But what we are having here is 40% HBE. So what it could be? We did an HB electrophoresis. I'm sorry for the image, it's very blurry, but this is what I had. This patient had an abnormal hemoglobin in the region of D. A, this is A, this is H, this is A, this is D. So the patient has a abnormal hemoglobin in the region of D. So on HPLC, it is HBE. It looks like HbA2 raised, could be HBE, but on electrophoresis, it co-elutes in the region of D. So what are the reason? What are the hemoglobins which come in D? Is D Punjab and D Iran on electrophoresis. So could it be D Iran? Yes, this was finally diagnosed as D Iran based on the finding of HPLC and electrophoresis. So one should ask a question. HB is common in India, in certain regions of India, the eastern part of the country, but a quantity of 43% in heterozygous state is generally not seen. So an electrophoresis should be used in conjunction with HPLC whenever it is necessary to arrive at a diagnosis. And here we see HBD Iran and the literature, it has a retention time of between 3.4 approximately to 3.6, which falls in the HbA2 window. And percentage of HBE is approximately 45%. So combining all these findings, the patient's husband had a heterozygous state for HBD Iran. To conclude for this case, not as a whole, that no single instrument, however sophisticated it may be, alone is not sufficient to diagnose all the cases. and judicious use of other investigation, ancillary investigation, other techniques should be always be done. Coming to our next case, this again is a 23-year-old female who underwent routine investigation at 14 weeks of gestation, shows mild anemia, hypochromic microcytic red cell indices, had a borderline low red cell count, and retic count was 0.5. This is a chromatogram. Again, we see a peak here. It is something which is not very commonly seen, and it shows that this peak corresponds to the HBC window. So HBC window, is it possible in India? It is highly unlikely that we get an HBC in India because it is most of the time seen in US and the American countries. So again, we should think what it is and how to confirm it. Could it be Q India with a retention time of 4.8? And it has coeluted at a retention time, but the Q India, no, because the retention time is approximately 4.8, but here the retention time is 4.8. So what should we do? We did a study for the of our parents, and what we found is one of the parent had a similar peak in the C window, that is 11.4. And here are the parameters for the whole family, the patient, the father and the mother. Here the C window in the patient and C in the father, but not in the mother. So whatever it is in heterozygous state. Could it be Q India 4.8? Unlikely. Why? Because Q India has a percentage which is a bit higher. So what we should do? Again, take the help of other method. So here we took a help of an electrophoresis which showed a band in the STG region. And since the patient had anemia, which was highly unlikely in HBQ, iron deficiency was ruled out. So we postulated that this could be something other than Q India, and did a molecular study, and this was confirmed to be HBO Indonesia. So these are some rare variants which we can find sometimes as a de novo mutation arising in our country also. And in such cases, whatever techniques we have in a resource limited setting may not be sufficient, and we may have to go for molecular confirmation of such cases. So again, re-emphasizing the fact, one method may not always be sufficient, and we should always look for try to reach such a diagnosis using the alternative methods. This is a 16-year-old male. He presented with anemia, having history of transfusion. He had hepatosplenomegaly. Clinically, a diagnosis of HAL intermedia was made, and we got a hemogram done, which shows a hemoglobin of 4.6. MCV was normal. We thought it could be because of previous transfusion. Then an HPLC at the same time was done. Again, this is what it could be. We are seeing HbF, which is very high, of around 80%. HbA is 16%. Could it be because of transfusion? Yes, it could be. HbA2 is 6%. In some cases of, in which cases we'll get A2 of this? Beta thalassemia trait. In some cases of homozygous beta thal also, HbA2 may be high. Homozygous beta thal is something which can have either low, normal or high HbA. So it can have all the three. So what is it? Is it homozygous beta thal which is presenting as a thal intermedia picture with some genetic modifiers? But then we had a look at this chromatogram tracings. Look at this. There is a slight hump in this. This is not straight. So slight hump in the A2P. So this hump in A2P is suggestive of something which we will see what it is. It is generally HB lepo. Now we wanted to confirm from where did it come. So what we did was we did a family study. So this is the hemogram of father, mother, and the brother. So father has a normal hemoglobin with normal indices. Mother has a bit low hemoglobin with microcytic indices. Brother has a hemoglobin which is still lower, but not as low as his sibling. So The brother is also anemic, but is not requiring transfusion, probably because as the other sibling is requiring regular transfusion, they have not moved. This sibling got ignored somehow. Looking at their HPLC tracing, we can see that the father has a hump here, which is very similar to what the child has. And mother, she is beta thalassemia trait with an HbA2 of 5.2%. And the brother, he has very characteristic finding like his other sibling, A2 of approximately 9 with a characteristic hump in the A2. So what it is, as I have already said, A2 has a lot of other hemoglobins in its window. So one of those hemoglobin is Lepo, and yes, it is. It could be Lepo trait, HB Lepo trait, and why? Because there is a characteristic hump in the peak which has been described in the literature. So to summarize this case, it's a 16-year-old male, anemia hepatosplenomegaly, characteristic hump in A2 peak, suggestive of HB Lepo. HbF is high levels in this patient and his brother. And important is father has the same A2 peak, which is suggestive of HB Lepo, but only in a carrier state. But why this patient is symptomatic? Because the mother is also beta thalassemia trait, and so they are now in a compound heterozygous state and presenting as a beta thalassemia intermediate and requiring transfusions on and off. So the percentage of tracings from hemoglobin alone will make a wrong diagnosis of either beta thalassemia, homozygous or trait, but we should look how that peak is, how that trace is. That is a characteristic hump, whether it is coming or not. And in this case, it was the point which suggested in towards the diagnosis of HB Lepo. This is probably the last case. Yes. So this was a person who came to us with a for screening of sports scholarship. Our company has a sports scholarship in which people who are very good in sports are selected for and they are given all the facilities for the training. So here what we see is a patient who has an abnormal peak here. So this peak is S window showing 63%. And F is high, 26%. So someone who is very good in sports with an HbS of 63%, can it be possible? He will have difficulties if he goes forward with his sporting career. So that is the reason we do this tracing. Someone who has sickle cell is then counseled not to take up sports as a career and provided with some alternatives. So in such cases, what to do? We did a HPLC of the father and the mother. That is a family study. Here again, we see the father, he has an HbS of 37%. The mother, she has an HbS is not there, but HbF is something which is high, that is 16.5. So why should a female who has been asymptomatic all her life should have an HbF of 16.5? So it could be hemoglobin, persistent hereditary persistence of fetal hemoglobin in a heterozygous state. He had two sisters also, so we did an HPLC of both the sisters. The elder sister, she had features which were similar to to her mother, and 17.4 HbF. So she again is something. She again is a case of hereditary persistent fetal hemoglobin, heterozygous state. But the younger sister, she was like the brother. She had sickle cell window also, and HbF was also high of 22%. So if we are not vigilant in the case of, in such cases, we can straight away make a diagnosis of homozygous sickle cell disease. And herein lies the importance of family studies, because when we did a family study, we found out that the father was sickle cell trait, the mother was heterozygous state for HPFH, and the patient was heterozygous for HPFH and compound heterozygous for HPFS and sickle cell disease, and the daughter, one of the daughters was again HPFS and sickle cell, and the other daughter was heterozygous for HPFS. So, what do we counsel such cases? See, these cases with high HPF, they generally tend to have less complications of sickle cell disease. But if they go on to following a career in sports, they can have repeated hypoxic conditions, and they'll have start having problems if they're not having enough. So the patient was counseled along with the family, and they agreed that the patient would not pursue sports and go into the studies further. It was also more important because once we had such condition of sickle cell, we do a family screening of all such cases, mother, father, and all the siblings, because we want to know the state of the other siblings also, so that they can be given a counseling before their marriage regarding the complications of the chances of having a child with a homozygous state. So it is very important that we should do a family study, call them, and do the counseling. In fact, we have been successful in doing it, and we have approximately more than 16, 1700 families we have counseled, and we have a data of that. And we have been successful in at least avoiding some of the complications resulting from the homozygous state. As I already said in the beginning, we are a cosmopolitan place. People from all around the country have come to join our Village Steel Plant. So we get a variety of mixtures of the hemoglobins. So in all such cases, a family study becomes very important, because if any of the family members is there, even if the mother, father, one of them is only thalassemia trained, we can tell that their family members get tested for it, and so that we can counsel them. So to conclude, I would say that HPLC is very helpful in diagnosis of hemoglobinopathies. Yes, it is, but clinical history, examination findings are equally important and are the clues to looking at the underlying disorders. HPLC is informative with regards to the expected percentage of various variants, but we should always look at the chromatogram pattern, how the graphs are formed, what are the expected patterns, like HBE is 25% to 30%, where if we are getting HB of 45, we should think of something else. And whenever there is a doubt, always do a family study and do use other methods to confirm your diagnosis. Thank you.
Thank you very much, Dr. Gurmeet. I think it was very extensive, and the cases I think you showed were really unique and very nice to explain, the patterns and also the deviations from normal. While we are waiting for some questions, I got some questions which got sent to me. If you could take them in the meantime.
Yeah, sure.
One is, I think you highlighted in between your cases. We all know that HPLC is kind of the gold standard these days, but you also highlighted very nicely that role of electrophoresis also in some of these cases. So if you could just summarize basically when would you require electrophoresis when HPLC has been done, and what are the clues on HPLC you will kind of make you run electrophoresis on the sample. That is one. And the second one, which is linked to that, is alkaline and acidic pH electrophoresis. So differences between the two, and how they help us in basically different scenarios. So these are the two questions for the time being.
So whenever there is an abnormal hemoglobin, say, as I said, the example was we get a window in P2 region. What we expect in P2 region is HBJ mirror. In India, we have HBJ mirror. So how to confirm whether it is HBJ mirror? One is you should go for a molecular confirmation. You can look at the mutation and confirm it, but it is not always possible because of cost constraints or some other reasons. So electrophoresis is very simple. It can be set up in a lab, in every lab in fact, and we can run it, and suppose in a case of HBJ merit, we'll get a fast moving hemoglobin. In a case of HBH, we'll get a fast moving hemoglobin. By fast moving, I mean that from the starting point, they go up to HPA. Something that goes beyond that is known as fast moving hemoglobin. So these are the points which can help us in confirming our suspicion that yes, we are dealing with J variant. It is an alpha chain variant, we know. An alpha chain variant, they are most of them fast moving on electrophoresis, and we can run it and see where do they go against our known samples. Now the second part is the difference between acidic and alkaline. The most common used is alkaline electrophoresis because it is easier to standardize. We have learned it. Everyone who has worked in at least someone who read pathology when I did a few years back. HPL, this electrophoresis was very commonly being done, and we are very well versed in it. But acidic electrophoresis is something which is very difficult to standardize. And so it is not very common to use. The difference is there are certain hemoglobins clusters which can be differentiated, say SDG. We can, when we do SD means D Punjab and G, and we can separate it using the acidic electrophoresis. They will go in different directions. But the problem is that A2 and E, again, they travel together. And it is very difficult to say what it is. Now, the same limitation is with HPLC also. A2 and E, they travel together. They co-elute together. So it is difficult to differentiate that. And the importance of capillary gel electrophoresis comes here, because that is something which helps us in differentiating whether it is a A2 or E.
Okay, so there are few questions in the in our chat box also. I think Neeta just put in, if baby is born to parents with sickle trait,
Yeah.
when would we advise HPLC in the baby when it's born to a sickle cell trait couple?
So there is we did a project when we got this machine. So we screened all neonates for HBS at the birth. The variant of Biorad, they have a special program for it, which is known as sickle cell short program. And it is meant specifically to be run for neonates. So if we run a sample on that program, we get only 2 peaks. One is HBS and one is others. So we know that there is some amount of HBS in it. But quantification at that time is not possible. So how to do it? We can do it after the baby reaches the age of 1. Because by that time we expect the HbF to fall at to less than 1% to approximately less than 2%. That is the adult level, and at that time we can get the true picture whether the baby is a trait or not. And of course, since only one of the parents was a trait, we can expect that they won't be symptomatic, and it will be only a trait.
Now, what are your comments on neonatal screening HPLCs which are done these days?
We did it at that time, and somehow we got results, but I personally think that it's not needed, because we can do it at later age. If it won't differentiate between thalassemia major. So what we are more interested is, because the presentation would be thal major, that we are more interested in looking, and it is very difficult at that time. HbF is always high. So in a setting in which if we are doing a research study, then it's okay. But routinely, somehow I am not very convinced. We can always do it at a later stage.
Yeah. Now there's another question which is on P3 peak.
Yep.
What does it denote, and does it increase with increase in HbA1c?
HbA1c P2 peak increases with HbA1c, not P3 peak. So P3 peak is something if the sample is old and it has been run after a few days. So it shows that the sample quality is compromised. And we should always take it with a clinical setting. And if it comes in a fresh sample, then we should think of the J variant and the group. but HbA1c is seen in variant, it is seen in P2, and that is we should keep an eye open for it. That can help us in some cases of detecting high HbA1c and looking for insulin dependent diabetes.
The next question is on how to differentiate delta beta thalassemia and
from HPF. Yeah, that's a very it has a very simple one-line answer. I had the same query all my life till I had a good fortune of listening to the talk of Dr. Barbara Bain herself. So this was the question I put her, and the one-line answer was HPFH is normocytic normochromic, delta beta is microcytic aneuploidy. Finish.
Yeah, so I think that's what I had. Any other questions anyone has? Well, I don't think there are any more questions. So thank you very much, Dr. Gurmeet, for your time. And it was an excellent session. And I forgot to ask you in the beginning, because we record these sessions, and we will be sharing these sessions with other people also. I mean, those who may not have been logged in today. So it will be a good resource for us for future as well. So thank you for your time again, and sharing your experiences. Thank you, Neeta, for getting Dr. Gurmeet at a short notice, and Ria and Echo for your platform and for your technical help. Thank you very much, and we'll see you next week. And you all will get us a survey also for the time change. I think we'll send it across tomorrow. And then hopefully we should come under consensus for a revised timing. Thank you very much. Thank you, Dr. Gurmeet. Have a good day.
Thank you, sir. Thanks.